Thank you very much. It's an honor to be here, and today I'd like to talk to you about susceptibility wave imaging of the brain. I want to thank my French and Israeli hosts. Merci et toda rabba. Today what I'd like to do is to discuss the role of susceptibility-weighted MRI in neuroradiology, initially talking about its value in detecting hemorrhagic products, but also showing some additional value of susceptibility-weighted MRI, particularly as it relates to research as well as in the detection of calcification and iron in the brain. What I'm not going to review, since I'm not a physicist and not a pulse sequence programmer, is the pulse sequence, but I will refer you to the initial reference from Mark Hakey in the American Journal of Neuroradiology 2009, which describes the pulse sequence. When we talk about susceptibility-weighted imaging, we're emphasizing the importance of proton relaxation enhancement, which is a T2 shortening effect that we see with the presence of blood products, specifically deoxyhemoglobin and hemosiderin. And this is due to the inhomogeneity, a local inhomogeneity, due to the presence of those blood products in a focal area. This causes T2 shortening, a T2 star effect, and susceptibility-weighted imaging is particularly sensitive to that T2 star effect. And it is, as I said, the major factor when we're looking at acute hematomas with deoxyhemoglobin and then in the chronic phase with hemosiderin. This is, for example, a case where you see the deoxyhemoglobin and the intracellular methemoglobin and hemosiderin. Deoxyhemoglobin dark on T1 as well as quite dark on T2 weighted scan from that proton relaxation enhancement T2 shortening effect. And you notice that there is surrounding edema, diagnosing this as an acute hematoma. Contrast that with this scan where it's dark on T1 as well as dark on T2, but there is no surrounding edema because this is hemosiderin. This is a hemosiderin stain or hemosiderin slit hemorrhage. On this sequence, what you're seeing is some bright area on T1 weighted scan. However, it is dark on the T2 weighted scan because of intracellular methemoglobin, which also has proton relaxation enhancement, a T2 shortening effect, as contrasted with the bright on T1, which is from proton-electron dipole-dipole interaction. Well, susceptibility-weighted imaging is a technique that is exquisitely sensitive to this T2 shortening effect. It's a 3D velocity-encoded graded echo pulse sequence, and this is as Hakey described it. And even when you compare gradient echo scanning to susceptibility-weighted scanning, you're able to see even more sensitivity to those T2 shortening blood products, such as deoxyhemoglobin or hemosiderin. When we do susceptibility-weighted imaging, it's a pulse sequence that does cost you in time. It's probably the longest pulse sequence that we have in our armamentarium. But as you will see, it is very valuable in selective settings that I will describe. When you have susceptibility-weighted imaging using it on the Siemens product, you get 4 different images. You get magnitude and phase images. The phase images are filtered. You then have what's called a susceptibility-weighted imaging. And then post-process, you do MIPS. But this time you're not looking at maximum intensity projection like you do for an MRA. You're actually looking for the minimum signal, the darkest signal. And we do that with the entire brain covered over 8 to 10 millimeter slices. So these are the 4 different sequences that you might see on an SWI pulse sequence. You have the magnitude, the phase, which is filtered, the SWI, and finally the MIP, which is the one that we usually use clinically to look for the blood products. As I said, when you have a typical pulse sequence in your brain protocol, you may have flare DWI, you may have the B0 of the DWI, and the T2 weighted scan. Remember that the fast Venecco pulse sequences are not very sensitive to blood products. The next most sensitive one that you might look at would be B0, because that at least is a gradient echo in most DWI sequences. But the susceptibility-weighted image is going to be very sensitive to the presence of deoxyhemoglobin in blood products. In fact, it's thought that the reason why you see the veins so well on an SWI MRI pulse sequence is because of the deoxyhemoglobin in the venous blood as opposed to the oxyhemoglobin dominance in arterial blood. So in this series of images, what one can see is the hematoma on the CT scan. This is a T1 weighted scan from the MRA. This is a T2 weighted fast echo scan. This is a flare scan. This is the B0, this is the diffusion weighted scan and the ADC map. And this is our SWI sequence. You see that there's blooming effect of the blood products because of its exquisite sensitivity to the proton relaxation enhancement. And it's been shown on numerous publications that when you compare the typical GRASP gradient echo sequences to the susceptibility weighted 3D sequence, that it is much more sensitive to the presence of blood products. And in fact, we used to have this concept of non-hemorrhagic shearing injuries from trauma. And it's been shown that SWI shows that many of these do indeed have blood products that were just not picked up on your gradient echo sequence. It certainly is much more sensitive than, for example, relying on a flare scan for a trauma patient. You might say, oh, well, you know, there are some white matter lesions here. Are these from shearing or whatnot? And here you have the SWI, where you see at the gray-white junction, these focal areas of blood clots that are not evident on your associated flare scan. In fact, we now have a differential diagnosis that gets expanded because of our increased sensitivity to these blood products. These little micro-hemorrhages that we've been describing with SWI have a broad differential diagnosis, which may be from trauma, they may be from your hypertensive encephalopathies, or amyloid angiopathy. And I'll describe amyloid angiopathy in a little bit greater detail in just a moment. You could see them from multiple cavernomas, hemorrhagic nets, etc. So we usually use the SWI sequence in the setting of stroke and trauma, but also for coagulopathies in our seizure workup to look for a seizure focus, because small cavernomas may be seizure focus foci that are not necessarily picked up with your typical fast echo pulse sequences, or even with gradient echo. And we also are using it in our dementia protocol because of these tiny little microhemorrhages that we're seeing more and more in patients who have Alzheimer's disease, or even those patients who have mild cognitive impairment that are at high risk for progressing to Alzheimer's disease. So let's move a little bit from the blood products in the brain to blood products in blood vessels. And it is true that SWI, because of its sensitivity to deoxyhemoglobin, it will find an acute clot within a blood vessel in your search for acute stroke patients. So here you see a patient who on the DWI has an infarct in the left side of the pons. And we look on the SWI and we see blooming effect within the basilar artery from the thrombus. And this is a different patient. This patient had a right middle cerebral artery distribution infarction. And this little dot of dark signal intensity, if you screened on multiple sequences, was out of proportion. This is a clot within the right middle cerebral artery seen on an SWI sequence, and the clot is seen on the MRA out in the periphery right here. Another example, this patient with a Wallenberg syndrome, a posterior inferior cerebellar artery infarction of the lateral medulla, and once again, blooming effect within the clot that occurred within the vertebral artery. And you can see the normal left vertebral artery and the occlusion of the V4 segment of the right vertebral artery demonstrated again by the blooming effect on the susceptibility weighted scan. And yet another example of that. So one thing that was interesting is that there has now been described an entity of diffusion susceptibility weighted imaging mismatch. So we know about diffusion and perfusion with tissue at risk. Well, Poland described in December 2014 a mismatch between areas of the venous signal that occurs within an infarct from slow flow, presumably, and the restricted diffusion. And they showed that that is, again, an area where you often will see stroke progression. So people are now talking about this mismatch between the area where you see slow venous flow here on the right side versus the diffusion weighted scan. And as you can see, this patient went on to infarct a greater portion of the right middle cerebral artery distribution than was initially seen on the DWI scan. So there's been a proposal that we should be looking at not just DWI-PWI mismatch, but also DWI-SWI mismatch as a prognostic factor for stroke progression. This is another article from July 2014 saying that when you have a mismatch and you reperfuse it, you have a very good outcome. So it is a prognostic factor for intervention with reperfusion, both with IV-TPA as well as intra-arterial therapy. And this was what they demonstrated, was when there was this diffusion mismatch with the perfusion, with the SWI, that the patient was able to recanalize and had a better outcome than those patients where there was not a mismatch. I talked about arterial thrombus. We really should also talk about the venous thrombus, which also is well demonstrated. As I said, the venous system is well seen with the SWI because of the presence of the deoxyhemoglobin. So not only will SWI be useful for demonstrating the hemorrhage, which is often associated with venous infarction. We say that 75% of venous infarctions are hemorrhagic, but it will also demonstrate the clot that occurs in the vessel, as you can see outlined here. So this is portions of the SWI with venous clot on the periphery in the middle cerebral vein, demonstrated by the arrows on this study given to me by Jennifer Lynn of Germany. And here again, showing the cortical venous thrombosis that may be demonstrated on the SWI. Now, the veins are already dark, so sometimes you may get confused about whether they're dark because of thrombus within them versus dark because of the normal venous flow. But this can be settled by doing the MR venography, as you see here. In this case, you see the occlusion of the superior sagittal sinus in this MR venogram on the bottom right, and these enlarged veins that were occurring due to collateralization, and some of them also with thrombus. I said I'd get back to you on amyloid angiopathy. Now, this is really fascinating. When about 10, 15 years ago, we used to say that you don't entertain the diagnosis of amyloid angiopathy until the patient's 60 years of age or older. And that was because you didn't really see these hemorrhagic areas in those patients younger than that. With SWI, we're now calling amyloid angiopathy in patients as young as 50 because we're able to see these tiny little microhemorrhages that even with radiant echo scanning we weren't seeing 10 years ago. So the age range of amyloid angiopathy has been dropped now into the 50s. And then the picture of amyloid angiopathy has radically changed. The description in my textbook in the second edition was about cortical lobar hemorrhages with amyloid angiopathy. Now we think of amyloid angiopathy as multiple punctate microhemorrhages with hemosiderosis, and I'll show you what that looks like. So this was the old version of amyloid angiopathy with a large lobar hemorrhage seen on the SWI, and then we saw multiple additional ones here. This was multiple cortical hemorrhages with amyloid angiopathy. However, what we're now seeing is that there's a predominance of microbeads, these tiny little hemorrhages that occur in the parenchyma, as well as superficial siderosis. And again, this is Jennifer Lynn's work, who is one of the individuals who's been doing a lot of work in analyzing patients who've had cerebral amyloid angiopathy. So this is from her publication. And as you can see, there are hemorrhages that can be seen on the gradient echo scan, but this is the portion of the susceptibility weight scan. You're seeing this hemosiderosis on the surface of the brain, as well as these tiny little dots of dark signal, which are the microhemorrhages. So our concept has changed from large lobar cortical hemorrhages that you could even see on CT to microhemorrhages, hemosiderosis, and maybe larger cortical hemorrhages. Again, this is the accompanying gradient echo scan showing that although you do see a few of these, you don't have that widespread disease of microhemorrhages that is so much more evident on your susceptibility weight scan Another example of some blood products that are seen in the subarachnoid space on FLAIR scan and on graded echo scan, and then we do the susceptibility weighted imaging. You're seeing that this represents peel hemosiderosis. In addition, there are tiny little microhemorrhages seen on the SWI sequence. We recently completed a study looking at the value of doing SWI in neonates who have hemorrhage associated with prematurity. Now, in most instances, you're not going to be doing an MRI in these patients. This is really a diagnosis that is made by ultrasound. But we wanted to know whether the performance of the MRI would add anything to the ultrasound that would change management. And we do have, proliferation of MRI machines at Johns Hopkins. I was describing that we have about 18 MRI machines in the Hopkins system. So we have ready access to MRI. So looking at the value of SWI to ultrasound in neonates. And this is what we found. We found that although ultrasound was very useful, that there was a role for SWI, particularly in the posterior fossa and in demonstrating parenchymal hemorrhage. So here, for example, is a grade 1 germinal matrix hemorrhage that most people would identify on the neonatal ultrasound. This is the analogous finding on susceptibility weighted scanning. We said this was graded as equal. But the findings that were not as readily identified were little microhemorrhages around the ventricles, as well as hemorrhages posteriorly around the occipital lobe. In this case, these were subdural hematomas that were occurring in a 34-week gestation, and also in the posterior fossa cerebellum, where ultrasound was not as accurate. So we found that SWI was superior to ultrasound in detecting some small intraaxial bleeds, some posterior fossa bleeds, as well as some of the extraaxial bleeds, but it really didn't affect management, and we're not advocating switching in any time from ultrasound to SWI. I've talked to you in multiple times about the blood products and the veins with SWI. As you would imagine, it's very nice for demonstrating developmental venous anomalies, or what we used to call venous angiomas. So here you see on a T2 weighted scan what some people would probably pass as a prominent vein. For those who are particularly observant, you may have seen this little dark signal here, but when you do the SWI, you see a neat, cathode medusae look to the developmental venous anomaly, and certainly once you do the post-contrast scan, we know that this is a DVA and something that we would not recommend any type of treatment for. They're very nicely demonstrated also in the posterior fossa, where you see this one draining towards the fourth ventricle, both on the SWI image as well as on the post-contrast scan. But were you not to do the post-contrast scan, if it was an unenhanced study, this is what you'd be looking for identifying DVAs with SWI. Since it's very sensitive to blood products, we're also able to see cavernomas very well. We're also able to see your capillary telangiectasia. So in the spectrum of occult cerebrovascular malformations, those being DVAs, capillary telangiectasias, and cavernomas, you see that SWI is particularly sensitive, demonstrating the hemorrhagic blood products at a time when most of us would dismiss the T2 and FLAIR scan. This is the post-contrast, and as one would expect with the capillary telangiectasia, they do have a little blush of enhancement. Here's another one, FLAIR scan and T2 weighted scan. Initially, on first pass, we were just thinking these were changes of small vessel ischemic change. However, on the SWI, you see that this patient has both capillary telangiectasias as well as developmental venous anomaly within the pons. And that combination of cavernoma, DVA, capillary telangiectasia, DVA, we say occurs in about 10 to 15% of cases. Another example, here we have one that from Sturge-Weber, where you see the prominence of the venous system on the post-contrast scan, as well as a little bit of volume loss. This is the SWI sequence, and this is another example of a patient with Sturge-Weber with leptomeningeal. So I focused mostly on hemorrhage, and now I'd like to talk about the other roles of susceptibility weighted imaging, particularly in research. These are little cupcakes that my wife made for my division. Now these are just walnuts with a little drizzle of red dye number 2. So we all have that problem of, well, how do we know whether it's hemorrhage or calcification? And the phase image of the SWI sequence is particularly useful because calcification, when it's purely calcification, is diamagnetic, whereas iron products, blood products are paramagnetic. And if you look at the phase dispersion, it will be greater with the hemorrhagic products. And so we wrote a paper on the detection of calcification as opposed to blood products in oligodendrogliomas, and showed that on this phase image, if you see this brighter signal intensity, that represents the calcification as opposed to blood products. And we wrote a paper that was published and showed that the addition of SWI was particularly useful in MRI for detecting calcification as opposed to the hemorrhage in patients who have oligodendroglioma. Another example that you see, this one showing the dark signal intensity in the SWI and the phase on the phase image, and then the calcification on the CT. So we wrote this paper, and we get a letter to the editor by one of Dr. Hakey's students saying that what Yousem et al. Wrote is only true if they have a right-handed scanner as opposed to a left-handed scanner. What? I don't know what that means. But according to the orientation of your magnetic field, they said that it may be bright or dark on the phase image when you have calcification as opposed to hemorrhage. And so, sort of like, okay, well, let's reverse our discussion and try to figure out whether or not our machines are right-handed or left-handed. But what has been nice is that a number of other people have looked at the same issue and have demonstrated that seeing the brighter image, for example, here we know that this is going to be calcification of the thallus. And therefore, whatever this is in terms of the phase signal, is going to represent calcification, as opposed to the cavernoma, which as you see has a different signal intensity than the calcification. So if you look at the choroid plexus, which we know has calcification, we can use that to determine which is the phase of the calcification without having to figure out whether we have a right-handed or a left-handed MRI machine. But people have taken this one step further, and again, this is publication from 2014, demonstrating that quantitative susceptibility mapping is particularly useful both in sensitivity as well as specificity for distinguishing between hemorrhage and calcification. And this QSM, quantitative susceptibility mapping, is the next phase of using your SWI pulse sequence. It does require post-processing, and this is from Chen's work, and this gets a little bit confusing because what they say is that the choroid plexus here is diamagnetic and dark on the QSM scan because it's calcification. However, what you see in the basal ganglia is really not calcification, it's more ferrocalcinosis, where you have iron and calcification, which accounts for why it is going to be bright on the QSM. Just as this subdural hematoma here, which is outlined on the CT scan, is bright. So this is the rationale for why on the QSM, what's dark is going to be calcification, whereas what's bright is going to be iron content. So this is another example of diamagnetic focal area here and here, and bright on the QSM. Calcification dark on the QSM, but bright on the phase image. And this is that example of it. Here it is, dark on the QSM, bright on the phase image. Big area of calcification here, a little clump of calcification. Your gradient echo shows the dark signal as well. However, there's a difference here between this dark signal on the QSM and this bright signal on the QSM, as opposed to your gradient echo where both are dark. So this is a demonstration of calcification as well as hemorrhage, both of which on a GRE are going to be dark, but they can be distinguished on the quantitative susceptibility mapping image. And this is one of the reasons why we're very enthusiastic about doing our research in QSM, and this is just yet another example of the same, demonstrating how quantitative susceptibility mapping can distinguish hemorrhage from calcification even better than the phase aspect of the SWI sequence. There have been other publications looking at value with QSM, and this is what has been described as the dual rim sign of abscess. So in this case, what you're seeing is a hypo-intense rim, the dark rim, on the outside with a hyper-intense inner rim. And that is what people are describing in an abscess as opposed to a necrotic mass or metastasis or GBM. And this, again, has to do in part due to the respiratory burst of the microbacteria that are converting deoxyhemoglobin, metahemoglobin, etc. from oxyhemoglobin. And this publication from 2012 described this finding, and as you can see, this is a GBM up front, which is up top, that does not have the same double rim sign versus the abscess, and they were able to distinguish the two very well using that finding with SWI. Sven Haller did a publication about patients who have mild cognitive impairment, and he looked at the presence of microhemorrhages in the brain. And here we're starting to have a really cool thing, and that is the blurring between amyloid deposition from Alzheimer's disease and amyloid from amyloid angiopathy. Same compound, different location. And what he found was that in controls, only 14% had microhemorrhages in this age group, this older age group. 33% of patients who had stable mild cognitive impairment had foci of microhemorrhage. But those patients who progressed from mild cognitive impairment to Alzheimer's disease over their follow-up period had a nearly double the rate of microhemorrhages. And so he is proposing that these can be used as a surrogate risk factor for progression from MCI to Alzheimer's disease. Not only that, but also looking at the iron in the basal ganglia. This is a new area of research that, again, I'm very excited about, that there is more iron deposition in the basal ganglia in neurodegenerative disorders. I'm running out of time, but I'll show you a couple of these examples. These are just some of his patients with MCI that have lots of microhemorrhages that progress to dementia. So looking at iron deposition in basal ganglia or in the brain has been shown to be particularly useful in neurodegenerative disorders. Here, Ravi Menon is using it in multiple sclerosis and shows that the disability of a patient in multiple sclerosis has a better correlation with the iron deposition in the brain from the neurodegeneration than the MS plaque volume or even the black hole volume. So this is part of his work on QSM and volume from total white matter damage on QSM correlated with the disability scale. At Johns Hopkins, we're doing a lot of QSM mapping. We're creating normative data maps for all different age groups. And we've started to look at patients who have various neurodegenerative disorders. The first one we looked at, and this was Peter Van Zal's group, was Huntington's disease. As you know, we would expect to look for something in the caudate nucleus and globus pallidus. This is a 46-year-old female control. This is a 41-year-old patient with Huntington's disease. And as you can see, based on the brighter signal representing more iron, there's more iron deposition in the caudate and the globus pallidus in patients with Huntington's disease. And this can be demonstrated here in the caudate nucleus and the putamen and globus pallidus region, as you see with the asterisks demonstrating p-value less than 0.001. Catasil, also looking at the basal ganglia in Catasil, showing increased iron in those patients with cerebral autosomal dominant with strokes and encephalopathy. Parkinson's disease. Let's look at this, the substantia nigra of patients with Parkinson's using QSM for iron content. The substantia nigra, patients with Parkinson's disease versus controls, as you can see, a very strong p-value. These are the substantia nigra down here, and you can see that those patients with Parkinson's disease, brighter signal intensity of QSM representing increased iron content. This This is part of his work looking at that iron content in Parkinson's with two different subjects, the control subject versus the patient with Parkinson's disease. Even in patients with multi-system atrophy, Parkinson's plus, one of the Parkinson's plus syndromes, you're seeing more iron in the lateral aspect of the containment in those patients who have MSA, and that's being used also. The susceptibility-weighted map images can also be used very nicely for targeting the subthalamic nucleus. You see here the subthalamic nucleus just above the substantia nigra, it's number 1. And then we're using SWI imaging with the neurosurgeons, so that way when they do the deep brain stimulation for the dystonia, they use the SWI to target the subthalamic nucleus because it naturally has more iron. So I hope that I've demonstrated for you that the susceptibility-weighted pulse sequence is very versatile, it's very useful. We're using it in more and more of our pulse sequence, and it's really ripe for research, particularly involved around quantitative susceptibility mapping, and that's why I'm so bullish on SWI. Thank you for your attention.